Hello friends, welcome to a new lecture today on MCQ session for esophagus. We deal with 10 MCQs. MCQ number 1. Conduit in gastric pull-up is based on. So when you actually remove the esophagus, the conduit for gastric pull-up, that is the conduit of stomach, is based on right gastric and right gastroepiploic artery. This is one-liner. Right gastric and right gastroepiploic. Then, what is the best substitute for esophagus? Best substitute for esophagus is stomach. Best substitute for short segment replacement of esophagus is jejunum. And best substitute for replacement of benign diseases like corrosive strictures is colon. Okay, but overall best substitute is stomach. Next, question number 3. The first successful esophagectomy was done by. Torek is the scientist who have done, is the surgeon who have done first successful esophagectomy is done by Torek. Then, commonest cause of mortality in Ivor-Lewis operation is. In Ivor-Lewis operation, this is a transthoracic esophagectomy where we give 2 incisions, one in the abdomen, second in the thorax, and we pull the stomach up into the thorax and we anastomose the stomach in the thorax with the esophagus. So, due to the anastomosis of esophagus and the stomach in the thorax, there is increased chances of anastomotic leak. So this anastomotic leak can be the most common cause of mortality. Then question number 5. Commonest benign tumor of esophagus is. Commonest benign tumor of esophagus is leiomyoma. Actually, there are some one-liners of leiomyoma. If you see, leiomyoma is the most common benign tumor of esophagus. Leiomyoma is most commonly seen in males. Leiomyoma is most common in the lower two-thirds of esophagus. Leiomyoma is the dysphagia is the most common symptom in leiomyoma. The most common investigation or the best investigation done in leiomyoma is barium swallow. The most common or best treatment in leiomyoma is enucleation. So all these are the most common in leiomyoma. Then question number 7. Endoscopic treatment of leiomyoma of esophagus is contraindicated due to. See, endoscopic treatment of leiomyoma is contraindicated due to the perforation, because there is increased risk of perforation in leiomyoma. So endoscopic treatment of leiomyoma of esophagus is contraindicated. Then question number 8. 40-year-old female presents with dysphagia to both liquids and solids and regurgitation for months. The dysphagia is non-progressive. What is the most likely diagnosis? Here the hints are female, dysphagia to both solids and liquids, and regurgitation. Non-progressive. So normally, in female with dysphagia and regurgitation, always think of achalasia cardia. Here it is said that dysphagia is non-progressive. Most commonly in achalasia you see progressive dysphagia, but that doesn't mean that there is no role of non-progressive dysphagia. There is non-progressive dysphagia, especially if there is long duration of dysphagia. If there is long duration of dysphagia, slowly there will be progression, and at the end progression will be stopped. So this is the diagnosis of achalasia cardia. Then question number 9. Dysphagia lusoria is due to. This is a direct question. It is due to compression of aberrant blood vessel, that is right subclavian artery compressing the esophagus, causes dysphagia lusoria. Then, most common site of iatrogenic esophageal perforation is cervical portion, especially at the cricopharynx. This is 10th question. Cervical portion, especially in cricopharynx, is the most common site of iatrogenic esophageal perforation. Question number 11. 40-year-old female presents with perforation of distal third of esophagus. Best form of management is perforation of distal third of esophagus is mainly seen. See, here the question is 40-year-old with perforation of distal third of esophagus. So in case of perforation, you should see it is a contaminated. See, here it is not due to iatrogenic cause. Here perforation can lead to contamination of the mediastinum because the contents of the esophagus empty into the mediastinum. So best management of this case is diversion and drainage procedures. So here you do esophagectomy with bringing the proximal end has fistula in the neck. You will do esophagectomy with bringing the proximal end has fistula in the neck. So thank you guys for watching my lecture. Thank you.